Appendectomy requires what anesthesia? Spinal anesthesia we are discussing. Spinal anesthesia. So guys, remember in regional anesthesia we are having spinal anesthesia, epidural anesthesia, caudal and saddle. Whereas we are also having peripheral nerve blocks, that is brachial plexus block, stellate ganglion block and ankle block. So first, starting with spinal anesthesia. Spinal anesthesia, what is the indication? It is usually used for below umbilicus short duration surgeries. Below umbilicus short duration surgeries. Okay, that is the indication of spinal anesthesia. Now there are many surgeries which I have already told you. What is the site where you insert the needle? Remember, you make the patient in a sitting position, or you can give in a lateral also, but sitting is more preferred. Okay, so sitting or lateral, what is the site where you have to insert the needle? As you are only blocking the lower extremities, you don't have to insert the needle in the cervical or the thoracic vertebrae. Directly insert the needle at the lumbar intervertebral space. Now in the lumbar intervertebral space, which lumbar intervertebral space? IV is not intravenous, it is intervertebral. Okay, which one guys? It is L3 to L5. How will you come to know this is L3 to L5? Again, there is a landmark, guys. What is that landmark called as? That landmark is called as Tuffier's line. Tuffier's line is nothing but you keep both the hands on the highest point of the iliac crust. Yani कि you are taking two hands and you are keeping on the highest point of the iliac crust and thumbs like this. The point at which where your both thumbs coincide, that indicates an imaginary line, that it's nothing but Tuffier's line, which is usually indicating the L3 L4 or L4 L5. Yani L3 to L5 space can be easily identified using Tuffier's line. Commonly it indicates L4 L5 space. So guys, you know the how to identify the space. Now, why don't you go for the L1, L2? Why? Because remember, in adults, the spinal cord is entering at the lower border of L1, between the lower border of L1 and upper border of L2. Hence, you avoid this space. Okay? You avoid this space. Now, needle that we use is what? It is thin bore dura separating needle. It is thin bore, which needle? Dura separating needle. Why? Because dura cutting needle will usually cause much damage to the dura. So as you can see over here guys, what is being done? You take the needle, you identify the space, and then you slowly insert the needle. As you are inserting the needle, what are the layers which are being pierced through the needle? That is very, very important. Now guys, look over here. As we are passing the needle, what are the layers which are commonly pierced? For that, you have to just remember a small mnemonic. If someone asks you, remember in spinal anesthesia, the site is important, the order of layers are important. This is very important. So if someone asks you what are the orders of layers, you have to answer them. Some say spinal instigates lethargy during anesthesia. Is it so difficult, guys? No, na. Some say spinal instigates lethargy during anesthesia. Okay. Some means what? S stands for what? It is skin. Next S stands for what? Subcutaneous tissue. Next S stands for what? Supraspinous ligament. Supraspinous ligament. Next I stands for what? Interspinous ligament. Interspinous ligament. Next, lethargy. L stands for what? Very important ligament, that is ligamentum flavum, the toughest ligament. On piercing of this ligamentum flavum, you will feel a sudden loss of resistance or a snap. That is very, very important, guys. Very, very important. Okay. Next is what, guys? Next is dura. And once you puncture the dura, the next layer is arachnoid. And once arachnoid is punctured, you are in the subarachnoid space that has the CSF. There is no subarachnoid layer, guys. There is subarachnoid space that has CSF. So that is regarding what, guys? That's regarding the order of layers that are pierced in spinal anesthesia. Now just look over this video, guys. I am giving spinal anesthesia to the patient. Now as I am passing the needle through the skin, the first layer is skin, Next layer is subcutaneous tissue. Next is interspinous ligament, ligamentum flavum, and dura is punctured. Arachnoid is also punctured. So once I puncture the arachnoid, I'm in the subarachnoid space waiting for the CSF. Just look over here. What is coming? Yes, I see the drop of CSF. That indicates I am in the subarachnoid space. Once I see this, what I'll do, I'll connect a syringe that has my local anesthetic, and first I will aspirate some CSF to confirm whether I am in the CSF exactly or not. Okay, that aspiration is called as barbotage, and then I give local anesthetic. Okay, so order of layers, I guess everyone is clear. Okay, which I have already told you: skin, subcutaneous tissue, supraspinous ligament, interspinous ligament. The most toughest ligament, just look over here. Toughest ligament is pure ligamentum flavum, then dura, and once you puncture the dura, subarachnoid will be there, then subarachnoid space, there you are giving the CSF. Done. Okay, now guys, which is the most commonly used local anesthetic in spinal anesthesia? Our hero, that is bupivacaine. It is the most commonly used local anesthetic in spinal anesthesia, despite the fact that it is the most cardiotoxic. Now you must be wondering, when it is the most cardiotoxic, why are we using bupivacaine? Remember guys, bupivacaine will cause cardiotoxicity if it is not given in the CSF and if it is given in the blood vessel. But here in spinal, you are clearly given in the CSF, so no chances of cardiotoxicity. Okay, so that's regarding the spinal anesthesia. Now guys, remember, sometimes we add some things to the local anesthetic in order to increase the duration of it. Those drugs are called as additive drugs. In additive, what are the drugs which are usually used? Opioids are used, adrenaline is used, bicarbonate, soda bicarb is commonly used and all. Okay, opioids are more commonly used. In opioids, you used fentanyl, you use sufentanil, you use alfentanil. But which is the opioid which is commonly avoided in spinal anesthesia, guys? It is remifentanil, commonly avoided in spinal anesthesia. Why? Because it has a side effect of, it contains neurotoxic preservative. Remifentanil contains neurotoxic preservative. Hence, it is avoided in spinal only in spinal anesthesia, not in all. Remifentanil is commonly used for daycare surgeries and all. Okay. Now, guys, a small question to you. What do you think? Which doctor is good? An overconfident doctor or a well-prepared one? Which doctor is best, guys? I usually prefer a well-prepared one. What is meant by well-prepared one? Well-prepared one means one doctor who is well prepared ahead of what? Ahead of complications. He knows what complications can happen. That's why he's preparing himself. So that kind of doctor you have to be, not an overconfident one. I have given 100 spinals, nothing will happen. When you say that, in that case only some problems will happen. So guys, remember how you will become a well-prepared doctor for spinal anesthesia. What I used to do, what I am doing, guys, is before giving spinal to the patient, I make sure that I have my emergency drug tray ready. What does emergency drug tray means? In the emergency drug tray, I keep 4 things ready. Then only I'll go for spinal anesthesia. What 4 things, guys? First drug I am keeping phenylephrine. Second drug I am keeping atropine. Third drug I am giving pethidine. And fourth I keep laryngoscope, ET tube, and adrenaline. If these 4 things are not there, I won't be giving spinal anesthesia. Even though they give me many thousands of rupees, but I won't give it. Why? Because first you have to be prepared of the complications, because in any patient any complication can happen. You have to be prepared. So guys, why are you prepared for this complication? Why phenylephrine or ephedrine? Why? Because remember, what are the complications that you can encounter? Imagine guys, you have given spinal anesthesia. Imagine kya, this is most common scenario, guys. After giving spinal anesthesia, you look at the monitor and suddenly you see 2 things. You see this thing and you might also see this thing. These things are common. Sometimes you might not see the heart rate of 46, heart rate might be 80, but this fall in BP is commonly seen. This is called as hypotension. The most common complication of spinal anesthesia is what, guys? It is hypotension. Why? Because as spinal produces sympathetic blockade, all blood goes and pools in the lower extremities, and there is no blood volume in the upper part of the body. That's why the patient will have hypotension. Now, for this hypotension, what you can do, the best treatment, if you see this, the best treatment is there in the emergency drug tray. What is that? The first drug, phenylephrine. If phenylephrine is not there, you can go with ephedrine. Okay, but you have kept that. Okay, now the second complication that could occur in spinal anesthesia is what, guys? The second complication that could occur in spinal anesthesia is, remember, the first complication or the most common complication is hypotension. The second complication is what, guys? Bradycardia. And we are not worried about bradycardia. Why? Because second drug what we have kept is atropine. Okay. Third drug that we keep in our emergency drug tray is what? Pethidine. Why? Because the third complication is what? Shivering, which is easily managed with the help of pethidine. Fourth complication is total spinal and high spinal, and fifth is total spinal anesthesia. High spinal means you want the drug till T6, but your drug has gone till T4. Yani ki drug has gone a level up, that is called as high spinal. Total spinal means the drug has gone into the intracranial segment. Now it has gone very much up. Patient is having difficulty in breathing, and if you don't manage, patient might develop cardiac arrest also. But again, are you worried about total spinal or high spinal? No, sir, I am not worried. Why? Because I am having this emergency drug tray where I have kept laryngoscope, ET tube and adrenaline. Why? Because if he develops total spinal, patient will have breathing difficulties. I'll intubate the patient with the help of endotracheal tube, and if cardiac arrest happens, I am ready with adrenaline. So this is regarding the intra-op complications. The most common is hypotension. These are the intra-op. Post-op complications after spinal anesthesia. The most common post-operative complication of spinal anesthesia is what, guys? Urinary retention. But guys, again, you don't have to worry about it. What we are doing nowadays is what? For every patient who is posted for spinal anesthesia, we are putting a Foley's catheter so that the patient does not develop this urinary retention. Okay, that's the most common. Next is headache. Headache nowadays is not seen. Why? Because we are using dura separating needle. But God forbid, after giving spinal anesthesia and after 12 to 14 hours, you get a call from the hospital that, doctor, today morning you gave spinal anesthesia. Now the patient is complaining of worst headache and all. In that scenario, what's the best management of headache, guys? Best management of headache is conservative management. What is conservative management meaning? You give coffee to the patient, you give NSAIDs to the patient, you give head low position to the patient, you give some fluid to the patient. Why? Because headache is seen due to the puncture of the dura. There is loss of CSF. You give the things that helps in building up the CSF. Okay, but that's the best management. But what is the definitive management? Close the puncture with the help of a blood patch. That is called as epidural blood patch. Epidural blood patch. Next post-op complication is cranial nerve palsy can also happen. Cranial nerve palsy happens with headache. Yani ki due to loss of CSF, there will be herniation of meninges, which will put pressure on the sixth cranial nerve, and patient will have palsy of the sixth nerve. So that's regarding the post-operative complications of spinal anesthesia. We also need to discuss some contraindications of spinal, in which condition spinal is never given. Now guys, remember what's the most common complication of spinal? It is hypotension. But if the patient is already in shock, will you give spinal anesthesia? No, sir. In shock, the BP is 70/40. If I give spinal, BP is gone. We can't give spinal. Next, if the patient is having a raised intracranial pressure and he's posted for appendectomy, will you give spinal? No, sir. As he's having raised intracranial pressure, the moment I give spinal, I try to give spinal, there will be gush of CSF. So I cannot give. So raised intracranial pressure is a contraindication. Shock is a contraindication. If the patient is having bleeding tendencies, coagulopathies, or a platelet count of less than 80,000 or INR value of more than 1.5, spinal is contraindicated. Why? Because spinal hematoma can occur if the patient is having fixed cardiac output lesion. Yani he cannot withstand hypotension, or he cannot withstand any hemodynamic changes, sudden hemodynamic changes. Their spinal is contraindicated. Or if the patient is having local site infection, spinal is contraindicated. And one of the most important contraindication is what? If the patient is refusing, don't force it. If the patient is refusing, don't force it. We have seen many cases. They are not back in India, but over here we have seen some cases that we tell the patient that spinal is best for you and all, and patient agrees also, and we give spinal anesthesia, and after surgery and all, the headache is commonly seen. But after surgery, some patient come back saying that no, doctor insisted and forced me for spinal, then only we went for spinal, and they do a case on the doctor. So these kind of things are there. So if the patient is refusing, no means no. You have seen the movie Pink, right? No means no. So no means no for spinal also. Okay. Now coming to the next is what? Epidural anesthesia. Epidural anesthesia means what, guys? Now remember, spinal was given for below umbilicus limited duration surgeries. Epidural can be given for below umbilicus longer duration surgeries such as total hip replacement, total knee replacements and all. Okay. And epidural can be used for multi-purposes. And multi-purposes means what? It can be used for labor analgesia. It can be used for if the patient is having thoracotomy pain or any kind of rib fracture, you can give epidural and you can place epidural. Remember, unlike spinal you were giving at lumbar intervertebral space. Epidural can be given at cervical, thoracic or lumbar depending upon for what purpose you are using epidural anesthesia. Okay, so what's the needle that is used in epidural anesthesia? This needle is very important, guys. It is Tuhoy's epidural needle. This needle is called as what, guys? Tuhoy's epidural needle. What is the size of this needle? It is 18 gauge. Length is how much? 9 to 10 centimeters. Now guys, remember, epidural is given for below umbilicus long duration surgeries. Okay, below umbilicus long duration surgeries, which I have already told you. The examples are total hip replacement, total knee replacement and all. Okay, site of epidural, it depends upon for what purpose it is used. Cervical is there, thoracic is there, and lumbar epidural. Okay, cervical for radiculopathy, cervical radiculopathies or any lymph node dissections, you can go for cervical epidural. Thoracic epidural can be used for thoracotomy pain, rib fracture pain and all. You can place thoracic epidural. Lumbar epidural is used for labor analgesia or painless labor, which is already given over there, or it can be used for long duration surgeries. Long duration below umbilicus surgery. Below umbilicus surgery. Okay. Next, guys. Next is called as caudal anesthesia. Caudal anesthesia, remember, caudal anesthesia is commonly used in children for what surgeries? Anorectal surgeries. Anorectal surgeries. What is the site of caudal epidural only? It is the sacral hiatus. Okay. And what is the last layer to be pierced in caudal? It is the sacrococcygeal ligament. Sacrococcygeal ligament. That's regarding the caudal anesthesia. Now guys, discussing about what? Right. Now starting with the nerve blocks. In peripheral nerve blocks, we are